In every stage of life, a woman has the opportunity to make important decisions that can maximize her health and prolong her life. At the Washington Women's Center, we have the in-depth knowledge and breadth of experience in all facets of women's health care. We're committed to helping women get started on and to continue on the path to good health by helping them make healthy decisions along the way and by showing the way to achieving balance and wellness. This series of women's health programs is designed to offer women of all stages of life the information they need to live a healthy life.
Thank you for inviting me. Thanks, Kathy, for inviting me. When I got this topic, I said, that's something really interesting. I need to learn more myself and share that with the audience. So here we are. Now, first question comes that what are the lipids, lipoprotein and cholesterol? What is it? We hear about it all the time. But lipids are the fat and fat-like substances. When it mixes with protein, that becomes lipoprotein. And cholesterol is when you leave animal fat either on the room temperature or in the refrigerator sometime, you see a thin, opaque, white layer, that is cholesterol. So that's the definition of lipid, lipoprotein, and fat, and cholesterol. They're greasy, gooey, and they're sticky. So what are the different kinds of fat in lipid or lipoprotein? There is a LDL, which is called low density lipoprotein, LDL. That is the bad fat. And HDL is high density lipoprotein, which is the good fat. And then there's triglyceride, short TG, that is also bad fat. So when we talk about the cholesterol, lipids, and lipoprotein, most of them are bad except HDL. Many times the patient will ask me that, doctor, I get all confused all the time. Which is good and which is bad? What is LDL? What is HDL? Can you explain me? And I have figured out a way to connect it. We all want to be healthy. So to be healthy, LDL should be low. So low L for L. L should be low for us to be healthy. And HDL, which is a high density lipoprotein and is good fat, should be high. So if you can't remember anything else, L should be low, H should be high for our good health. So hopefully you will not forget it now. The next question is, where does it come from? It comes from two sources. As you can see, it comes from the food we eat, the food, and our body makes it. So about 20 to 25% of the fat, the cholesterol in our blood comes from the food, and rest comes from the body. Our body makes it. So if you think about this, that if for practical purpose we went on fat-free diet, zero fat, no fat, which is you can't eat fat-free diet forever. 1 or 2 days you can do it probably, but you can't live on the fat-free diet. It's necessary. Then if you start with a cholesterol of 400, it will go down to 300, 320. So we can do so much with the diet. There are other factors we need to consider. Now, we talk about the cholesterol and fat and lipoprotein and all that. Why should I worry about it? We should worry about it because when it's in excess, when the levels are high, what it does to our body, it start depositing, making plaque, and plaque can build up over time and start rupturing and then this can really blow up completely. The lipoprotein, lipids, they are needed because our cell wall is made of lipoprotein. So it's essential for life. The hormones which are essential for life, they are cholesterol. It's needed for the brain function. So we can't live without lipids and lipoprotein. So it's essential for life in certain level, but when it goes higher, then creates problem for us. The next slide is about the same. The plaque buildup starting breaking up and breaking up a little bit more. Then, let's see. This is what really happens in the life. That over the period of time, tens of years, the plaque build up and builds up and builds up. It's like a volcano. And it ruptures, and guess what it did? It blocked the complete circulation. So when this happens, then the blood supply to that part of our body is completely obliterated. There's no blood going to them. The other thing, what can happen when it was just beginning of rupture, then a little portion can go dislodge and go further down and block the arteries at later in the body. So these kind of two things can happen. Either it clogs the artery there locally, or the dislodged piece can go and block the artery further down. Now, when that happens, then what happens? If there was a plaque which got dislodged and went to the brain and cut off the circulation, then the person gets a stroke. When it went, same thing happened within the artery supplying the heart, then the heart attack. For the arteries supplying the kidneys, the slow buildup can cause the kidney damage over the period of time. And main artery is called aorta. It can balloon up and cause aortic aneurysm. So it just balloons out. And then slow buildup in our legs can cause peripheral vascular disease, or the circulation is not so good in the legs. When you walk, it hurts. So either the slow buildup and or the rupture can cause all of these kind of problems. That's why we need to worry about it. And that's how it affects our body. Now, are the women different? Yes, they are different. How are they different? Early in our lives, when the children are growing up, the boys and the girls, they are same. They have same lipid profile, there's no difference. But when the men or the little boys become to the age of puberty, their hormones, the male hormones go up. So the LDL, and LDL, remember, that's the bad fat, goes down. No, the HDL, the HDL, which is the good cholesterol, goes down. So the male hormone cause the HDL to go down, and this is the disadvantage the men have. On an average, there is a 10-point difference between men and the women starting at that age. And that protection the woman has from the woman hormone, estrogen mainly, goes on until the menopause. At the menopause, we lose that hormone, or it sort of goes down slowly. that's the time we lose that advantage we had over the man lipid profile. So that is the reason women are different. So premenopausal women will have better cardiac profile or lipid profile because they will have higher HDL, about 10 points, and also the LDL, low density lipoprotein, their makeup is different also. The size of the particle of LDL is larger in women. So they are less atherogenic, so they protect the heart more than if somebody with the smaller particles. So smaller particles are more sticky and gooey and they make plaque much more. The pregnancy, the data is very limited. So the only thing I can share with you is this, that they have found that women who have had 6 or more pregnancies, they have higher cholesterol. Now, I do not know whether this is something, because if you have 6 or 8 or 10 kids, you don't have time for yourself, you're not eating right, you're not exercising, maybe that's what it is, or there's something else, we just don't know. So data is very limited. Okay, as we age, the HDL goes up, and it goes up a little bit more in men than in women. But difference is very little. It's not significant. Triglyceride also goes up. And again, it goes up a little bit more in women than in men. So one thing is HDL going up is good. Triglyceride going up with the aging, not so good. The factors which affect the lipid profile. The smoking increases the LDL, the bad fat, and also decreases the HDL. So we have 2 problems. The bad fat went up, and at the same time, the good fat went down. Not the best thing. And if a premenopausal woman is smoking, it makes it almost equal to men. So advantage we had, 10 points, is lost. So it's better to quit. The diet in low in fat and calorie decreases everything, including the HDL. So it decreases the HDL, the LDL, and triglyceride, everything. So you will say, why am I eating this diet? It's not good for me. But if you see the ratios, if everything is going down, triglyceride went down, LDL went down, that was really good for us. With that, HDL also went down okay. And you're exercising, eating right, so you're taking care of yourself. So that risk is worth taking. Exercise also has the same effect on the woman. When women exercise, which is like 30 minutes, 3-4 times a week, something like that, it decreases the HDL, which is not a good thing. Also, it reduces the LDL. So LDL level is much higher. So when it goes down, that is really good for us. But with that, HDL goes down a little bit, few points, it's okay. We are up and around, exercising, active people, joints are moving, it's always good. Blood pressure will go down, blood sugar, it will help the blood sugar. So exercise, even after resulting into a little bit low HDL, it's okay, we should exercise and we should eat that diet. Okay, when we put on weight, especially the weight when we put on our trunk, the central obesity or truncal obesity, different terms used, by itself is a negative effect on the the lipid profile. So weight is not the good thing. Then if somebody has diabetes, with the diabetes, the profile we see is increased in LDL and triglyceride, which is bad, and also the HDL goes down. This is what happens when somebody develops diabetes. So that diabetes itself, it becomes a risk factor for the coronary artery disease or cardiovascular disease. Alcohol, it increases coronary heart disease. And hormones, as we were talking earlier, estrogen increases the HDL, that's the good thing, and decreases the LDL. So this is the good hormone. And we naturally have it until the menopause, and then we'll talk about the hormone replacement therapy. If somebody is on hormone replacement therapy, this will be the advantage you will keep. Progesterone, the other hormone, works the other way, but this effect is more pronounced than progesterone effect is. So as a net, we have advantage. Oral, no, let's go back. Oral versus transdermal hormone. The question comes sometime that I'm not taking the pill form of hormone. I'm taking the patches. So oral, it has more positive effect, and transdermal has less. Natural versus synthetic. Synthetic are synthetic, so they are mostly more potent, and natural are a little weaker. So when should we screen the woman? When the woman has no risk, and I need to emphasize this, that these recommendations are for no risk. If there is a risk factor, then it becomes a different scenario. So up to 45, we are okay, because the natural protection we have as a woman, it stays up to that age, give and take few years. If there is a risk factor, if somebody has diabetes, there's a family history, you're smoking, or whatever the risk factor is, then you start early. And these are the guidelines given by the US Preventive Task Force. So their guidelines are a little bit more liberal. So that's where these numbers come from. Now, as we all know, that the cardiovascular disease, that includes everything, includes coronary artery disease like heart attack, angina, all that, stroke, kidney problems, leg problems, all of those things together. Big toll. And the half of that is heart problem. When we have that many deaths, that many people are living with all different kind of cardiovascular disease, all different kind of all problems. And the women who are at risk, that's even much higher. So long story short, it's a major problem in our country. This nurses study I wanted to put in some slides here because I thought it was very interesting. The study, as you can see, is they took, the study period was 1980 to 1994, and what they did, they took this period and then went back to the women and did another survey. What they found in general in the community in our country, that there was a major change in lifestyle of the people. What had happened that women were smoking much more around that time or before, and around this time the smoking rate went down quite a bit. And other thing what happened, that before this time around here, we were used to of eating more natural foods and things like that, and here we started eating more processed foods and just food on the go, so to speak. So that was the change in the diet, which led to putting on weight. So these were the three things they noticed. And also their conclusion was that the cardiovascular disease was the leading cause of death. And the cardiovascular disease went down 30% around that time. So something changed. Maybe they're smoking. These were the conclusions. There's not too much explanation for that in that study. And obviously, we live longer, we have more problems, and if we reduce the risk, like smoking and diet and start exercising, if we did that, this can go down. So these, looking at this time, it sounds like it's very common sense, what are they talking about? But that time, I think that was a good conclusion, and what they did, they had 85,000 women subjects. So it was a large study, and it was a very good study. Now, the recommendations change so often. These are the recommendation for American Heart Association 2007 update, and prevention of the coronary vascular disease in female. And again, these are mostly talking about the primary prevention. And what is primary prevention? Prevention of cardiovascular disease before you know you have a disease. A secondary prevention is when somebody has had a heart attack or a stroke or some problem, we know that there is a disease, then we try to minimize, want to treat the risk factors. That is secondary prevention. So we are talking about primary prevention here. Obviously, if you're smoking, please stop smoking. And nowadays there are a lot of options. There are classes, there are nicotine patches, gums, inhalers, all different kind of things. And then there is a new medicine which has come out, has been good. I have used it. It's called, I have used it, two or three patients who have had problems in past quitting, they have been able to quit. So if that's the case, please talk to your doctor and see what you can do and what the doctor can do for you. As we talked earlier, that weight gain is by itself is a risk factor. So putting on weight is not the best thing. And more so when we have, our body is made to carry certain weight. And all of a sudden, if we put 50 pounds, 100 pounds extra weight, as I say that our feet are just our feet. They are going to cry. They will let us know. We'll have not just the heart problem, we'll have problem with our feet. We can't walk. Our knees are going to hurt. So all of those things are going to, we are going to have problem with that. Workout of 30 minutes every day, or at least 3-4 days a week, is good enough to maintain our weight. Of course, it's going to depend upon what our dietary intake is. It's as simple the what goes in, what goes out. So, for example, if you want to increase your bank balance, what do? You write big checks and don't take out the money too much. And if you want to drain your bank account, what you want to do? You don't put in any money and you write big checks, a payout. So, same way, if you want to lose weight, we have to control the calories and exercise in addition, and if you want to put on weight, the other way. On an average, if we want to lose 1 pound a week, which is a good healthy weight loss, we have to go down, go negative at 500 calories every day. So, if a woman needs 1500 calories to do the daily function of her life, she has to come down to 1000 calorie intake every day to lose 1 pound of weight every week. And if we are on the other side, if we are taking 500 calories extra every day than we need. So, if I needed 1500 calorie, I am using 2000 calories. By the end of the week, we will have 1 extra pound on our body. If somebody wants to lose weight, then we have to do more exercise and watch our diet. So, that exercise is more like 60 to 90 minutes, a lot of exercise. Give you an example that if you are walking, brisk walk, 15, 16 minutes a mile, 2 miles, that by doing that you will lose about 250 calories, about there, and you came home and I said, oh my God, I just walked 2 miles and I'm just so tired and I need to eat some breakfast or need to eat something. One toast without any jam or jelly or anything, no butter, is 200 calories. So, you are a wash almost. So, think about this either. To get rid of calories we get from one toast, we have to walk 2 miles, lot of exercise. So, losing weight is a different story. Okay, the diet wise, increase consumption of fruits, vegetables, whole grain, fish, these are the good things. And once again, that even the more vegetarian diet, it has meat, but if you are just vegetarian, this is going to decrease your HDL, as you remember. But the little bit decrease in HDL is worth taking as compared to the decrease in LDL and triglycerides and just eating right. Because when you eat more fruits or vegetables, you get all natural vitamins, antioxidants, those kind of things. You don't have to take those pills. Lower consumption of fat, especially the saturated fat, less than 300, it should be milligrams. It shouldn't be grams. It's a typo here. So, to give you an idea, 1 egg yolk gives you pretty much daily requirement of fat. So, 1 toast and 1 egg yolk, remember that. The monosaturated fatty acids are better. Polysaturated, that's the bad kind of fat.
So mono, okay.
Yeah.
Thank you.
Something like nuts. Nuts are really good. It's fat, but 1 handful of nuts is about 200, 250 calories. So, when I tell my patients that your HDL is low, eat some nuts. And after that, I tell them that if you are going to eat a handful of nuts every day, then you need to make an adjustment about your diet. Somewhere else you have to decrease the calories. Because if you keep eating what you were eating and start eating nuts, by the end of the month, you will have about 2 extra pounds. Yes?
What makes one crave salt?
You know, as they say, the most tasty things in your life are not good for your health. So that's where it is. The, okay, a word about blood pressure numbers. 120/80 is good, and lower is better. If you're once in a while, maybe once or twice a week, I'll have some patients who will say, oh, I really have low blood pressure, I am having a problem because it is so low. It is 110/64. That's not a problem unless you're symptomatic with this and there is a medical problem you're having with that. But that number by itself is a good blood pressure, and I would say you should be happy because you have one less thing to worry about. So desired is 120/80. If it goes between 120/80 and 139/89, somewhere there, we have to have the cutoff. Lifestyle changes. They cut down the salt in your diet, start exercising, and watch your diet. And if it's more than 140/90, please see the doctor. Lipid profile. And once again, I need to emphasize this, that you will hear and see all those numbers, all different kind of numbers everywhere. This is for the woman who has no risk factors. So with total, we like to see 200 or below. LDL 130 or below. HDL 50 or above, because that's the good fat. And triglycerides 150 or less. Okay. A word about aspirin. That aspirin is not recommended in a woman less than 65 years old. Now you will say, I hear everywhere that everybody should take aspirin. We are talking about the woman who does not have any risk factor, doesn't smoke, no high blood pressure, no diabetes, no known heart problems, then we are okay. Because when you take aspirin, it has benefits and it has risk. So we always, when we are taking medicine, we are talking about risk and benefit ratio. So in the woman who is healthy, no risk factor, the risk of taking aspirin before age 65 is more than the benefits. Now, 65 and above, you can either take 81 milligrams every day, or you can take 100 milligrams every other day. So depending upon if you're good in tracking, oh, I took the aspirin yesterday, I don't need to, this is my day off, I'll take it tomorrow. Hormone replacement. Now, hormone replacement therapy is an entire lecture by itself. But what I would say here is this, that before July of 2002, every woman after the menopause was supposed to be on hormone replacement therapy because that was the standard of care. If I did not put my woman who was postmenopausal on hormone replacement, I was not practicing standard practice. But there was a study came out which told us entirely opposite of what we were practicing. They said, again, the risk and benefit. If this is the medicine you were supposed to take for the rest of your life after you stopped having a period. So there were risk and benefit ratio. And that study told us that risk is much higher than benefit is. So it's not worth doing it. So the benefit, even now we know that the hormones increase the HDL and decrease the LDL. So that's the good part of it. But we are human being, we are not just the heart or not just the bones. So we are going to do what is good for our body, not just for our heart or just the bones. So those are the highest risk of taking the hormones is increase in breast cancer. It is, if you take hormone replacement therapy, it is good for your bones. So in your particular case, what it is it good? What the benefit is there and risk is here, you take it. Talk to your doctor. If it's the other way around, which is most of the cases, you don't take the hormone. So that's where we are. So hormone replacement therapy is not recommended either for primary or secondary prevention. And we talked about what is primary and what is secondary prevention. Antioxidants and vitamins. Once again, these are not, and I'm talking about the pill form. We need to eat good nutrients, fruits and vegetables. When we are talking about fruits and vegetables, the dark color vegetables, the red, the yellow, orange, berries, cherries, all of those things, they are good for you. So those things you need to eat. But is the pill needed? No, it's not recommended, and it doesn't help. Now, how do we treat the woman? And this is not going to go into detail what medicine, what side effects and all that. This is general I'm going to talk about. Now, the high-risk woman should be treated as men. So as aggressive as we can be. When they are treated aggressively, their regression of the disease is more or better than the men. So if you're treating a high-risk woman, the result is better. Because woman is high risk, and that's the tricky thing. High-risk woman has to be treated with the medicines. So when that happens, the regression is going to be better. Statins, these are the medicines used most commonly. They cross placenta. So we should not use these drugs in the childbearing age group. So woman who's trying to get pregnant, who can get pregnant, should not be treated. So we should not consider treating the woman who is even thinking about getting pregnant. And when it crosses the placenta, it causes the congenital deformities. And these studies are the animal studies, because this is not something we can do on the human being. So these are the animal data. So for that reason, avoid statin in childbearing age group. And breastfeeding, it goes in the milk. So once again, you don't want to treat those women. But the good part is that I've been in practice about 20 years and change. I was just thinking about it, that I have not treated a premenopausal woman with the medicines. I have not come across the woman whose profile is so bad that I have to put her on. This is so true. When I was going through the literature survey, it was really just thought about the practice, and that's true. And I see at least 2 or 3 men every week where their HDL is sometime as low as 20. The worst I have seen is 17. And their triglycerides are sometime like 500 up to 1,000. LDL is high 200s or high 100s. So I treat men all the time, but I have yet to treat one woman under the age of 45 with the medicine. So I think nature has given us some advantage here. Thank you very much. Thank you for inviting me. Yeah.